So now we are going to say about Seven Samurai and the Secret Mission. I have named the second arch as Seven Samurai Arch. Seven Samurai is a world famous group. They will do assassination of famous personalities. They will do gangster-like activities and will gain the attention of the people. So he is the actual hero of the Seven Samurai. He is the main coordinator. So we are going to see his story. So, the entire idea of Seven Samurai Secret Mission is facial nerve. Almost 75% of the course of the facial nerve is inside the ear, and the diseases are also studied under ENT. But 25% are being covered in general surgery. But here we are going to see about facial nerve. That is, again, facial nerve is a nerve of second pharyngeal arch, that is hyoid arch. We're going to see entirely from the origin of the facial nerve to the terminal branches. So this is how it works. So the facial nerve is actually supply for second arch. So what is the structures formed from second arch? Yes, muscles of facial expression. Then so you remember, yes, here styloid process, stylohyoid ligament, upper part of the hyoid bone, upper part of the body of the hyoid, and lesser horn. These are the structures formed from the second arch. Now coming to the derivatives, a step is styloid process, stylohyoid ligament, upper part of body of hyoid plus muscles of facial expression. So this is the movie Seven Samurai where they were very famous for their assassinations. So we are entering into the course of the facial nerve. The facial nerve starts at the pontomedullary junction, then it recedes backwards like this to form facial colliculus. At the floor of fourth ventricle. Then the facial nerve will enter into internal auditory meatus, where it will be having Bill's bar and horizontal falciform crest. So above there will be 7 up, that is our facial nerve. Below there will be 8 down, that is our cochlear nerve. Here there will be superior vestibular nerve. Here there will be inferior vestibular nerve. Fine. Then it enters into bony canal called fallopian canal. So the fallopian canal is a stronger canal, bony canal, which makes the facial nerve or protects the facial nerve from injuries. Then it will take here. Then it will form labyrinthine segment, which is the smallest and thinnest portion of the facial nerve. It will be around 3 to 5 millimeter of length. Then it will form the first turning into the ear. Before that there will be formation of geniculate ganglion. Okay, so that will be geniculate ganglion. So at the geniculate ganglion, just before the first genu, there will be first branch, that is greater superficial petrosal nerve. Then there will be formation of tympanic or horizontal segment of the facial nerve. Then there will be formation of second genu. Then there will be masted or vertical portion of facial nerve. So there will be no branch from the tympanic segment. From the labyrinthine segment there will be GSPN. From the masted segment there will be nerve to stapedius as well as cauda tympani nerve. So these are the branches inside the ear canal. Then the facial nerve will exit the ear canal through the stylomastoid foramen. The stylomastoid foramen, at the stylomastoid foramen, it will give to posterior auricular nerve. Then it will give nerve to digastric and nerve to stylohyoid. Then it travels into the face along the substance of parotid gland. Along the substance of parotid gland to give 5 terminal branches. 5 terminal branches are temporal, zygomatic, buccal, martial mandibular, and cervical. So, temporal and zygomatic will form from same segment. Martial mandibular and cervical will form from same segment. Buccal will have branches from both segments. The temporal branch will innervate the temporalis muscle as well as frontalis orbicularis oculi corrugatus superciliary. Zygomatic innervate oculis. Buccal will orbicularis oris, buccinator, and zygomaticus. Marginal mandibular will innervate the mentalis. Cervical branch will innervate the platysma. So, marginal mandibular is an important nerve because this nerve is the susceptible nerve in total parotidectomy. If this nerve is damaged, it leads to mouth deviation. So angle of mouth deviation. So now again entering into our story, I am going to introduce you one of the most villainous group of ever in the world. They are the Seven Samurai group. The Seven Samurai group has so many members. So their ultimate aim is to make the people suffer, create hatred against the government, to make stunts, motor stunts at the bus terminals, but still they are having a cool attitude. Finally, they will be having a taste of victory. So why they are doing this? To make the people suffer by crying. What is crying? It's nothing but lacrimation. Just here, secretomotor supply of facial nerve. So there is general visceral efferent. So general visceral efferent and general visceral efferent both are parasympathetic supply. That's all. Then they will create hatred against the government by spitting. So by creation of saliva from the salivary glands such as submandibular gland, salivary gland, and sublingual salivary gland. Done. Then they'll create terminal motor stunts, bus terminals. They'll create motor stunts to attract the public. So terminal motor branches is nothing but somatic visceral efferent. So general somatic efferent, which is a sensory supply to posterior superior wall of extraordinary canal. If you're having extraordinary canal like this, as we already seen, so pinna has 3 nerve supplies, extraordinary canal has 2 nerve supplies, middle ear has mainly one down nerve supply, but there will be crossing over between pinna. Yeah, pinna nerve will also supply the extraordinary canal. Extraordinary canal nerve will also supply the pinna, but the odd man out we could see here is the posterior superior wall of the extraordinary canal, which is supplied by 7th cranial nerve. So this is significant in vestibular schwannoma. Here there will be involvement of the facial nerve from outside, so it will create only sensory loss. The sensory loss is called Mr. Hitzel creates Hitzelberger sign. Then there will be chorda tympani, make the people taste the suffering. So taste sensation to anterior to third of tongue. Okay. Now entering to the length of the facial nerve. The length of the facial nerve, the meatal part is 8 millimeter, labyrinthine part is 4 millimeter, tympanic part, that is horizontal part, 11 millimeter, mass and vertical segment 13 millimeter. Okay. Landmarks of the intra-tympanic part is very important in MCQ point of view. The genital ganglion. The genital ganglion is just above that. So consider this to be the middle wall of the middle ear cleft. Here we'll be having our process cochleariformis. So here we'll be having posteriorly oval window, round window. So just above superiorly and lateral to the process cochleariformis we are having geniculate ganglion of the facial nerve. So again, genital ganglion of the facial nerve becomes like this. Then there will be lateral semicircular canal. So it will adjacent with the lateral semicircular canal. Then becomes the vertical part after formation of second genome. So after formation of second genome, there will be vertical part. The vertical part will give to the nerve to stapedius and chorda tympani nerve. By formation of chorda tympani, there will be formation of chorda facio angle, which is important while doing surgeries. Then there will be then it lies close to the short process of incus and brumate. Then it descends along the tympanomastic suture line. You come out of the extracranial part while doing. So this is our ear to come out into the substance of the parotid. While traveling to the substance of the parotid, it is much important during the parotid surgery. So during parotid surgery, we should identify the patient nerve, or else we will damage the terminal branches of the patient nerve. While doing so, there are two methods: anterograde method, retrograde method. The anterograde method has triangle pointer 1 centimeter deep and inferior to the triangle pointer. Styloid process. So here in this styloid process, the facial nerve will be superficial to the styloid process. Then there will be posterior diagnostic. Here we will be having hyoid. So posterior diagnostic attaching to the mastoid process. So just superior to the upper border of the digastric muscle, we'll be having our facial nerve. Again, we'll be having squamotympanic suture. The term squamotympanic suture is also related to the facial nerve extra-temporal area. So parotid surgery. So we are seeing about parotid surgery. Parotid surgery, we can do either superficial parotidectomy or total parotidectomy. For only the superficial lobe is involved, we can do superficial parotidectomy. Superficial and deep lobe are divided by facio-venous plane of Patty. It's divided by actually retromental vein plus facial nerve, which divides the parotid into two. So why are we doing parotid surgeries? So we'll have a look upon the parotid surgeries done for mainly pleomorphic adenoma, Warthin tumor, or malignancy, epidermoid tumor, advanced cystic carcinoma. So in these instances we can do. So if benign, we can go for superficial So if it's malignant, we should surely undergo total parotidectomy. While doing total parotidectomy, we should identify the patient now using those pointers. So the important post-surgical complication is, as I already said, there will be deviation of angle of mouth due to involvement of marginal mandibular. Then there will be Frey syndrome or gustatory sweating. Frey syndrome and gustatory sweating. Frey syndrome means so while doing the surgery, we are compromising the parasympathetic supply of the parotid gland, that is secretomotor fibers. But the secretomotor fibers will regenerate by the help of sympathetic nerves. So while regenerating, the skin stimulation can stimulate the parotid gland and it will increase the salivary production. Then gastritis sweating. Similarly, the parasympathetic supplies will be cut off, then the sympathetic supply will be regenerated by skin neurons. So the skin stimulation can cause sweating for B stimulating the gustatory stimulus. So the important thing we should look upon is the difference between UMN and element facial palsy. So UMN facial palsy is different from element facial palsy because at the level of the origin of the facial nerve there is some difference. So till the nucleus of the facial nerve, it has both sides applied due to the bilateral innervation of the upper motor neuron fibers. Lower motor neuron fibers is innervated one side only. But the strange thing about upper motor neuron lesion is only the upper half of the face is innervated. Okay, so if upper neuron palsy affect means opposite side facial nerve will compensate for the affected upper half of the face alone, but lower half will be not compensated. So the lower half of the face opposite to that of the affected facial nerve will undergo palsy. So there will be only deviation of angle of mouth, loss of nasolabial fold, and there will be asymmetrical movement of the musculature of the mouth. But element facial palsy, one half is affected, one half is completely affected. There will be loss of forehead wrinkles, there will be loss of nasolabial fold, deviation of angle of mouth to the unaffected side. Then there will be drooling of saliva from the affected side. So these are the changes we could see in element palsy. Simply, UMN, in upper motor innervation, upper motor neuron fibers has bilateral innervation only for the upper half of the face. Face. So now we are going to discuss about only the element palsy. The most common type is idiopathic element palsy, which is our Bell's palsy. So we'll be having Bell's phenomenon, which is unable to close the eyes completely. There will be epiphora. There will be asymmetry of the face. There will be dribbling of saliva. There will be noise intolerance because the facial nerve will supply the stapedial muscle. The stapedial will help for stapedial reflex. So that will be inactive. So there will be noise intolerance, loss of taste due to corner tympanic nerve. So the treatment for Bell's palsy is you can start prednisolone 1 milligram per kilogram body weight for 5 days, then taper after 10 days. So most common etiology can be viral etiology. So we can start oral acyclovir 200 to 400 milligram 5 times a day for 10 days for Bell's palsy also. So now we need to learn upon the important electrical test done during facial palsy. The nerve excitability test, electromyography and electromyography. In nerve excitability test, there are two types: minimal excitability and maximal excitability. So a minimal current is given to watch for facial twitch. So the minimal current required to produce the facial twitch is obtained for both sides of the face. So if the affected side requires more ampere compared with the unaffected side, it shows that there is degeneration or vision of palsy on on that side. So normally we will be having 500 milliampere as the current. So 500 milliampere current should produce a facial twitch for normal side. Okay, maximum stimulation test. So the electric stimulus is given to produce maximal facial movement and both sides are compared. If the one side movement is absent or reduced compared with the opposite side, then it indicates degeneration of that side. So nerve excitability test we are having minimal and maximal stimulation test. Electroneuronography. In electroneuronography, what we are going to do is the nerve is stimulated at stylomasted foramen and percentage of degenerated fibers calculated. So if there is greater than 90% degeneration even after 2 weeks of palsy, it indicates poor recovery. That is, spontaneous recovery is very poor in this patient. And also we can use that following the surgery, whether the facial nerve is recovering following surgery or not. Electromyography is nothing but we are inserting electrodes into the orbicularis oculi and orbicularis oris. Sorry, it's only orbicularis oris muscle. So to watch for the movement of the face following stimulation. So in this there are various inferences. Each inference give different comment. So if there is a polyphasic potential that is obtained, it means regenerative process of the palsy is underway. If there is a fibrillation like this, so it indicates element denervation but viable motor end plates. If there is no straight line, this long-term denervation, we can do nothing with that. So now we are entering into syndromes with facial palsy. The main syndromes we could study in it is Ramsay hand, Rosenthal, and Mobius syndrome. So Ramsay hand syndrome is nothing but herpes zoster oticus. Here there will be presence of human papillomavirus. Sorry, there will be presence of herpes zoster virus at the genital ganglion. So, following immunocompromised state, there will be reactivation of the virus at the genital ganglia, which produces facial palsy along with vesicles over pinna, and sometimes fifth and eighth cranial are also affected. It is called Ramsay-Hunt syndrome. The patient will carry at least a facial palsy and vesicles over the pinna. So now we are entering into Melkeson-Rosenthal syndrome. We'll be having swollen lips, fissured tongue, and facial palsy. Then fractured temporal bone. This is our temporal bone. So this is the squamous part, this is the mastoid part, this is the tympanic part, this is the styloid part. But the petrous part we will not be able to look at lateral viewing, whereas it could be seen from interior like this. Here inner ear will be lodged. Okay, so this is our petrous apex. This is our squamous, this is our mastoid, this is our styloid. So if we are going to look our temporal bone in this manner. So if any fracture line traveling transversely, it is transverse temporal bone fracture. If it travels longitudinally, it is longitudinal fracture of facial nerve. This transverse fracture. So, but the pathway of the facial nerve, you just remember, it goes like this. then it turns and goes like this. So in this, the longitudinal fracture line may or may not involve the facial nerve, but transverse fracture line will invariably affect the facial nerve, and there will be short facial nerve palsy. But it is quite less incidence, but our longitudinal fracture will be having more incidence, but facial palsy will be less compared to that of the transverse fractures. Which of the following statement is false regarding facial nerve? So it is a mixed nerve. Yes, it carries both sensory and motor supply. It is covered by fallopian canal throughout the course. No, it is not covered by fallopian canal throughout this course. Only at some areas. Labyrinthine part is the narrow part. Yes, it is the narrowest and smallest part. Chorda tympani is a branch. Yes, chorda tympani is a branch along with nerve to stapedius and greater superficial part of nerve. So the correct answer is covered by fallopian not only throughout the course, only at the intra-temporal course before formation of geniculate ganglia. False statement automatically Bell's palsy except most common cause. Yes, idiopathic most common. Yes, surgery is the best mode of treatment. Steroids have a medical method. So surgery is not the best mode of treatment. We should wait and watch for the palsy to settle down. So surgery is the last resort of hope. Yes. A 30-year-old male had a history of trauma with a temporal bone fracture 3 days back. His facial examination was normal but decreased lacrimation. So we will go into the branches of the facial nerve. So this is our lacrimary part. This is our geniculate ganglion. We are GSPN. We are getting nerve to stapedius. We are getting carotid one. So here he is having a temporal bone fracture. They didn't mention it as transverse or longitudinal fracture, but just said they having the facial examination was normal but decreased lacrimation alone. So the facial examination is normal, so which means the dermal branches are normal. So they didn't comment about the taste. So cognitive will be normal. They didn't comment about the stapedial reflex or noise intolerance. So the nerve stability is normal. Only the lacrimation affected due to GSPN involvement. So the GSPN is affected, which indicates the site of lesion is genital ganglion. So nervous intermediates. Nervous intermediates is another name for Wrisberg. I already said Wrisberg family. So the sensory nerves of the facial nerve will group together to form nervous intermediates, otherwise called facial nerve. So the sensory branch of the facial nerve. So what are the nerves it involves? As I already said, the nerve to the posterior superior external canal. So then there is also secretomotor fibers that is going through GSPN and also chorda tympani nerve. So these nerves will group together and come in a single nervous intermediate mode. Thank you.